Welcome back to Week 9, Part 2. This lecture will discuss cardiogenic shock. So let's think back to the cellular level. At the cellular level, we have the exchange of oxygen and nutrients, and that is essential to life. When a cell experiences a state of hypoperfusion, as in shock, what happens is the demand for oxygen and nutrients exceeds the supply at the microcirculatory level. And so shock is characterized by this decreased tissue perfusion and impaired cellular metabolism, which is essential to life. So there's an imbalance in the supply demand for oxygen and nutrients. Shock can be classified as low flow or distributive. So low flow is cardiogenic and hypovolemic shock, and distributive shock is septic, anaphylactic, and neurogenic shock. Although the cause, initial presentation, and management strategies vary for each type of shock, the physiological responses of the cells to hyperperfusion are similar, and that's what I'm going to discuss here. Cardiogenic shock occurs when either systolic or diastolic dysfunction of the pumping action of the heart results in compromised cardiac output. So it's all about cardiac output. So during decreased cardiac output, you have decreased filling of the ventricle, which will result in decreased stroke volume. And despite treatment, mortality rates for clients with cardiogenic shock ranges from 50 to 80%. So it has a very high mortality rate. Precipitating causes of cardiogenic shock include myocardial infarction, cardiomyopathies, which are a thickening of the ventricular muscle, a blunt cardiac injury such as a stab wound, severe systemic or pulmonary hypertension. So think back to when we spoke about pulmonary hypertension and the impact that that has on the heart system. Myocardial depression related to metabolic problems. Cardiac tamponade is when the fluid is in the pericardium, which is the sac around the heart. It builds up and it results in compression of the heart. And then, as I've said, myocardial depression from metabolic problems. So think of your metabolic alkalosis and acidosis. The early clinical presentation of a client with cardiogenic shock is similar to that of the client with acute decompensated heart failure. The clinical manifestations include tachycardia, hypotension, a narrowed pulse pressure, and pulmonary congestion. So you'll hear crackles in the lungs. So what is a narrowed pulse pressure? It's the difference between your systolic and your diastolic pressure. And so trauma causes a low or narrow blood pressure. So you have a narrowing of the numbers in your blood pressure. So instead of 120 on 80, you might have 120 on 100. And so what it suggests is significant blood loss and insufficient preload leading to reduced cardiac output. So it's one of those early signs. So when you listen to the individual's lungs, you will hear an increased respiratory rate, but you'll hear pulmonary congestion, so crackles. In addition, you'll see that the patient's cyanotic, so they're pallor, cool, clammy skin. They have decreased capillary refill time, and they'll feel anxious, confused, and agitation. So all the things around decreased cardiac output. If you're doing your hemodynamic monitoring, you'll find that the cardiac output is low because the heart has an inability to pump blood forward. So it's going to result in a low cardiac output. And if you look at the hemodynamic profile, your pulmonary arterial wedge pressure and pulmonary vascular resistance is going to be increased. Because remember, pulmonary arterial wedge pressure will tell you if the heart is in heart failure because there's an increase in fluid, the inability of the heart to pump, so there's an increase in fluid. And the pulmonary vascular resistance is that inability for the heart to pump out because the vascular system, the pulmonary vascular system, is vasoconstricted in a compensatory mechanism. You're also going to see decreased renal perfusion and a decreased urine output because of the decreased cardiac output. So basically you have this low blood flow that's happening. So let's go through the initial stages. So the initial stage of shock that occurs at the cellular level is usually not clinically apparent. But what's happening is you have these small changes in metabolism taking place from aerobic to anaerobic. So it's going from oxygen metabolism, which is aerobic, to anaerobic, because remember, it's not getting enough oxygenated blood to the tissues. So lactic acid will start to accumulate and must be removed by the blood and broken down by the liver. And the process requires unavailable O2. So you start to develop this metabolic acidosis. The compensatory stage is when the person or the client starts to develop symptoms and it's clinically apparent. But these tend to be a little bit, the next few stages tend to be a little bit overlapping between the compensatory, progressive, and refractory stages. And so in this stage, the body activates its compensatory mechanisms in an attempt to overcome the increasing consequences of anaerobic metabolism because it's trying to maintain homeostasis. And the client's clinical presentation begins to reflect the body's responses to the imbalance in oxygen supply and demand. So you're going to see the baroreceptors in the carotid and aortic bodies are going to activate the sympathetic nervous system in response to a decreased blood pressure, and it's going to cause vasoconstriction because it wants to shunt the blood only to those vital organs. You're going to have a decrease in blood to the kidney, which activates the renin-angiotensin system, and that's going to tell the kidneys to increase the venous return back to the heart to try and increase the cardiac output and the blood pressure. One of the classic signs of shock is the drop in blood pressure, which occurs because of a decrease in cardiac output and that narrowing of that pulse pressure. You're also going to have impaired GI motility, so there's a risk for a paralytic ileus, and you're going to have cool, clammy skin. And if it's a septic patient, you can expect the skin to be warm and flush, but we're talking about a cardiogenic shock patient here. So the skin is going to be cool, clammy from the blood being shunted away from those periphery to those core organs that need it. Something else that happens is the shunting of blood from the lungs. And so the shunting of blood away from the lungs increases the patient's physiological dead space. And the dead space is the amount of air that does not reach gas exchanging units and any inspired air that cannot participate in gas exchange. And so the clinical result of an increase in dead space is a ventilation perfusion mismatch. Some areas of the lungs participating in ventilation are not perfused because of the decrease in blood flow to the lungs. And you'll see this with the arterial oxygen levels. They'll decrease and the rate and depth of respirations increase to compensate. The myocardium responds to the sympathetic nervous system stimulation and the increase in oxygen demand by increasing the heart rate and the contractility. And so this is almost putting an even greater stress on the heart because of the sympathetic nervous system trying to get the oxygen back to the oxygenated blood back to the heart. The coronary arteries also dilate in an attempt to meet the increased oxygen demands of the myocardium. So if the perfusion is corrected, the client recovers with no residual sequelae. If the deficit is not corrected, the client enters the progressive stage. So this is a very important piece here, is you want to prevent the client from moving into the progressive stage. So the progressive stage of shock begins as compensatory mechanisms fail. Aggressive interventions are needed to prevent the development of multi-organ dysfunction syndrome. So this is where you don't want to go, where all the organs become involved related to shock. At this stage, you're going to see changes in the client's mental health status, and those are important findings at this stage. So in the progressive stage, you're going to see the hallmarks of decreased cellular perfusion and altered capillary permeability, a leakage of protein into the interstitial space, and increased systemic interstitial edema. Because of the increased systemic interstitial edema, the patient may develop a condition called Anasaka. Anasarcal is a medical condition. It's characterized by widespread swelling of skin due to the movement of fluid into the extracellular space. So fluid leakage will affect the solid organs and peripheral tissues, and it also causes decreased blood flow to the capillaries, the pulmonary capillaries. So let's talk about the pulmonary system. So the pulmonary system is often the first to display signs of dysfunction as blood flow to the lungs is already reduced. So in response to the decreased blood flow and the sympathetic nervous system stimulation, the pulmonary arterioles constrict, resulting in increased pulmonary artery pressure. So you'll see this on your hemodynamic monitoring. As the pressure within the pulmonary vasculature increases, blood flow to the pulmonary capillaries decreases and the ventilation perfusion mismatch becomes even worse. Another key response in the lungs is the movement of fluid from the pulmonary vasculature into the interstitial space. As capillary permeability increases, the movement of fluid to the interstitial spaces results in interstitial edema, bronchoconstriction, and a decrease in functional residual capacity. So again, all these things are happening in the lungs as a result of the compensatory mechanisms and the overwhelming compensatory mechanisms unable to respond to the shock. With further increases in capillary permeability, the fluid moves to the alveoli with resultant alveolar edema and a decrease in surfactant production. The combined effects of pulmonary vasoconstriction and bronchoconstriction are impaired gas exchange, decreased compliance, and worsening ventilation perfusion mismatch. Clinical manifestations are an increased work of breathing, so an increased respiratory rate, crackles, and overall increased work of breathing. The cardiovascular system is profoundly affected. Cardiac output begins to fall, and that results in hypotension and marked decrease in coronary artery, cerebral artery, and peripheral artery perfusion. Changes in the patient's mental status become apparent in this stage, as I've already discussed, because of the hypoperfusion. Capillary permeability continues to increase, enhancing the movement of fluid from the vascular space into the interstitial space. And you get this sustained hypoperfusion results in weakening of peripheral pulses and ischemia of the distal extremities. Myocardial dysfunction from decreased perfusion results in dysrhythmias. Myocardial ischemia, so chest pain, you're thinking about having a myocardial infarction, as well as the prolonged effect of this decreased perfusion will start to have effects on the kidney and the renal system. Renal function is impaired during this stage, and so the urine output will be decreased. And if we look at the blood work, we'll see that our BUN and our serum creatinine levels are elevated. So I'm going to go back here. The end result is a complete deterioration of the cardiovascular system. Moving on to other body systems. So the GI system is also affected as the blood supply to the GI tract is decreased. The normally protective mucosal barrier becomes ischemic, and this ischemia predisposes the patient to erosive ulcers and GI bleeding. And so that increases the potential risk for bacterial translocation from the GI tract to the blood, increasing the risk of septicemia. And also the decrease in perfusion to the GI tract also leads to a decrease in the ability to absorb nutrients. Other systems are also affected by the sustained hypoperfusion in this stage of the shock. The loss of the functional ability of the liver leads to a failure of the liver to metabolize drugs and remove waste products such as ammonia and lactate. Jaundice results from the accumulation of bilirubin, and as the liver cells die, if you do your blood work, you'll find that the liver enzymes become elevated. The liver also loses its ability to function as an immune organ. And so again, bacteria may translocate from the GI system to other places in the body, such as the bloodstream. And so that increases the development of bacteremia or septicemia. Dysfunction of the hematological system adds to the complexity of the clinical picture. The patient is at risk for development of DIC, which is a disseminated intravascular coagulation, and it's a condition in which the blood clots form throughout the body, blocking small blood vessels. And you can see the enormous problem with that. Already we can't get enough blood back to the heart because of hypoperfusion and out to the other organs that need it. And if DIC starts to develop, you're starting to block these small vessels. So let's move into the final stage of shock, which is the refractory stage. And in this stage, we have, again, exacerbation of anaerobic metabolism from peripheral vasoconstriction and decreased cardiac output. You have the accumulation of lactic acid, so you have a metabolic acidosis happening, and this constantly increasing capillary permeability with the leakage of fluid into the interstitial space. So the patient is going to demonstrate profound hypotension and hypoxemia, as well organ failure. And in this stage, recovery is unlikely. You have failure of the liver, the lungs, and the kidneys, and that will again accumulate waste products such as lactate, urea, ammonia, and carbon dioxide. So let's look at the diagnostic studies. So first of all, obtaining a thorough medical and surgical history and a history of recent events, such as surgery, chest pain, trauma, provides valuable data. So why is this person in shock? Now, there's no single blood test to determine shock, but these are some examples of ways that you can start looking at your diagnosis. So typically, the blood studies, apart from your typical CBC, Chem 7, which is your electrolytes, your BUN, your creatinine, elevation of lactate is one of the key indicators of shock, and this shows decreased tissue perfusion. So absolutely, a lactate level will be done. And if the lactate is above 4, that gives a good indication that decreased tissue perfusion is happening. 12-lead ECG is also done to look at the cardiac system to see if there's any development of angina or ST depression or elevation. Chest X-ray to look at the lungs. Continuing pulse oximetry and hemodynamic monitoring will be started. So this is a patient that's going to be going to the intensive care unit. So again, early recognition and prompt intervention are the critical factors in the successful management of a patient experiencing shock. So I'm just going to go through some general management and then into a little bit more specific related to cardiogenic shock. So first of all, assessment skills, urgent communication with a rapid response team is very important to prevent the decline to the progressive or the refractory stage. General management strategies for a patient in shock begins with ensuring that the patient has a patent airway and oxygen delivery is optimized, so your ABCs. The cornerstone of therapy for septic, hemovolemic, and anaphylactic shock is volume expansion with prompt and aggressive fluid resuscitation in order to restore that tissue perfusion and improve the hemodynamic status. However, fluid is given cautiously for cardiogenic shock, and that's because the heart probably won't be able to tolerate a large amount of fluid. And so a lot of the therapy for cardiogenic shock focuses on drug therapy to improve the tissue perfusion. And we'll talk about vasoconstrictors and vasodilators. The other point that you may not consider is the importance of malnutrition, and that protein calorie malnutrition can set in very quickly. And so the importance of probably having a patient on an NG tube or TPN if required. So let's look specifically at cardiogenic shock. The overall goal is to restore blood flow to the myocardium by restoring the balance between oxygen supply and demand. So remember I said that you need to be very cautious with fluid replacement. So specific measures to restore blood flow include thrombolytic therapy. So maybe they have a clot somewhere, and if you give a high caliber thrombolytic therapy, you can break down that clot. Maybe this individual needs to go for a cardiac catheterization, and it's typically performed very soon when someone goes into cardiogenic shock. And so you're doing an angiogram to see if the patient could have a PCI, remember those coronary angioplasty with or without stenting, may be performed during the cardiac catheterization. Other measures could include maybe they need emergency revascularization surgery, so a coronary artery bypass graft surgery, or maybe it's the valve that's causing the problem and they need a valve replacement. But until these interventions are performed, the heart must be supported to optimize stroke volume and cardiac output in an effort to facilitate optimal perfusion. So let's talk about how we do that. So, as I've said, the care involves hemodynamic monitoring. Drug therapy will include the following. You may give a nitrate, which is a vasodilator, to dilate those coronary arteries and have that rich blood come back to the heart. You may give a diuretic to decrease the amount of blood that's coming back to the heart to decrease the stress on the heart. You may give a vasodilator to decrease the afterload, the pumping, the ability for the heart to pump easily. And so decreasing the afterload will put less pressure on the heart and allow oxygen-rich blood to get out. And you may give a beta blocker to maybe slow the heart rate down and improve the contractility. Other things are the use of circulatory assist devices. An intra-aortic balloon pump just takes the pressure off the heart, and a ventricular assist device also assists the heart in pumping better. And there could be a need for cardiac transplantation as an option for a small and select group of clients with cardiogenic shock. So let's talk about nursing assessment. So the initial assessment is always geared towards the ABCs of airway, breathing, and circulation. So that's your first part. The second part is doing a focused assessment. So the further focused assessment will look at tissue perfusion and includes evaluation of the vital signs, peripheral pulses, level of consciousness, cap refill, looking at the skin, so the temperature, the color, the moisture, and urine output. As the shock progresses, the client's skin would become cooler and mottled, urine output would decrease, peripheral pulses will diminish, and the neurological status will decline. So after assessment, we think about planning, and our first thing we think about planning is we want to prevent shock. And so the nurse must be able to identify patients at risk. So who are those patients? The patients who maybe are older, have a debilitating illness, are immunocompromised, who've had an MI, who've had a sustained surgical or accidental trauma, and just really any of those individuals who are at risk for decreased oxygen delivery or tissue hypoxia. And so planning is essential to help prevent shock after a susceptible individual has been identified. And so what are your planning for your overall goals would be to restoring adequate tissue perfusion. You want the individual to have normal vital signs, recovery and return of organ function, and prevention of progression toward those complicated states that are related to prolonged states of hypoperfusion. So let's look at our implementation. So the role of the nurse in shock involves monitoring that patient's ongoing physical and emotional status to detect those subtle changes in the patient's condition, planning and quickly implementing nursing interventions and therapy, evaluating the patient's response to therapy, providing emotional support to the patient and family, and collaborating with other members of the health team to coordinate that care. So let's look at some nursing implementation by systems. So the neurological status, you're going to be assessing the client's neurological status, including orientation and level of consciousness, at least every hour or more often. The client's neurological status is really the best indicator of cerebral blood flow. So be aware of the clinical manifestations that may indicate neurological involvement, such as a change in behavior, restlessness, hyperalertness, blurred vision, confusion, paresthesia, so numbness. What about the cardiac system? So heart rate, rhythm, blood pressure, if they have a line in place, a hemodynamic monitoring line, you're going to be looking at the different pressure lines, so the central venous pressure, the PA pressure. You're also going to be monitoring cardiac output and other pressures within your cardiac monitoring. And you're looking at trends in these parameters. And so they're important, more important than the individual numbers. The patient's ECGs should be continuously monitored to detect dysrhythmias, and heart sounds should be assessed for the presence of an S3 or an S4 sound. The presence of an S3 sound may indicate heart failure, and the frequency of this monitoring is decreased as the patient's condition improves. The respiratory status, it must be assessed frequently to ensure adequate oxygenation and in order to detect complications early and provide data regarding the patient's acid-base status. So you're going to be initially monitoring the rate, depth, and rhythm of the respirations as frequently as every 15 to 30 minutes. Pulse oximetry using a client's finger may not be accurate in a shock state because of poor peripheral circulation. And so in this situation, you may attach the probe to the ear, nose, or forehead to increase the accuracy. Arterial blood gases could provide a more definitive information on ventilation and oxygenation status and acid-base balance. And most patients in shock will be intubated and on mechanical ventilation. So they're going to be in the ICU setting. Hourly urine output measurements assist the adequacy of renal perfusion. A urine output of less than 0.5 mils per kilogram per hour may indicate inadequate kidney perfusion, so you would need to figure that out from the patient's weight. BUN and creatinine values are also used to assess renal function. And what you'll be doing with these is you would be monitoring the trends in the creatinine and BUN levels to assess the renal function. Monitor the temperature every 4 hours if normal, but in the presence of an elevated or a subnormal temperature, obtain hourly core temperatures. Cap refill should be assessed and skin monitored for temperature, pallor, flushing, cyanosis, diaphoresis, and piloerection. That's those trills that you get where you get those bumps on your skin and the hair stands erect. So that's that chills. And bowel sounds should be auscultated every 4 hours, and abdominal distension should be assessed. If a nasogastric tube is inserted, drainage should be checked for occult blood, so blood in the stool, as well as the stools can be checked, so to see if the patient is bleeding. In and outs, fluid and electrolyte balances will be checked. Oral care for the patient in shock is essential, and passive range of motion should be performed 3 or 4 times per day. Hygiene is especially important for the client in shock because impaired tissue perfusion predisposes the client to skin breakdown and infection. Assessing the level of anxiety, pain, and fear is really important because fear, anxiety, and pain may aggravate respiratory distress and promote the release of catecholamines. So thinking about what medications can be given PRN, talking to the client, maybe a visit from the clergy, having family there, comfort measurements, providing privacy, call light within reach. And then the last part after implementation is obviously evaluation. You're hoping that you get a normal or baseline ECG, blood pressure, central venous pressure, and PA readings, normal temperature, warm and dry skin, the urinary output is improved, normal respiratory rate and saturation above 90, and verbalization of fears and anxieties. And so you're hoping a decreased verbalization of fears and anxieties. And then what about if the patient has survived? Remember, there's a very high mortality rate, and typically patients who do survive have had a long stay in intensive care units. And so rehabilitation of the patient who is recovering from shock necessitates correction of what was the precipitating cause to begin with. and prevention and early treatment of complications. And so complications may include a decreased range of motion and decreased physical endurance because of ICU stay, bed rest. There may be an impact on the renal system, so maybe renal failure has taken place. Typically, there's a development of some type of fibrotic lung disease, such as acute respiratory distress syndrome. So there's going to be some lung issues. And patients typically require diverse services on discharge. So some type of transitional care, rehabilitation, and home health care. So I'll stop there, and I will see you in our Zoom class to discuss this further.